It is my pleasure to welcome all of you here this evening. My name is Ken Mosesi, and I'm the Executive Director of the American Fertility Association, and we are thrilled to be back in Miami Beach. I was here about 10, 11 days ago for Pride and had an amazing time, and we love the community here, and we're growing to love it more and more every day. And anything that we can do to help all of you on your path to parenthood, we want to do. So a little bit about the American Fertility Association. We're a national nonprofit organization that began about a dozen years ago, primarily to help women who are struggling with infertility. And over the years, our mission has expanded. And it's expanded to be an inclusive family-building organization whose mission is to help all hopeful parents find their unique path to parenthood. We adopted in 2008 an official strategic goal of family building for the LGBT community. I also want to thank Dr. Fernando Ackerman for being here this evening. Dr. Ackerman is from Fertility and IVF Center of Miami. I had the privilege of working with him at Pride. He came out in the sun and was there for a few hours with us, doing a great job. And since my Spanish is limited to 2 words. It was great to have Dr. Ackerman there to deal with the Spanish-speaking population and make them feel welcome and at home as well.
And I want to thank you, everybody that is here, and you already named all the persons that make this meeting possible, okay? So I'm not going to repeat them at all, okay? You may see as a disadvantage that you need to go through all of these different type of evaluations and procedures to get pregnant. But let me tell you that I see this as potentially a big advantage, because when I see the heterosexual couples in my office that they've been through infertility, generally they have not done any type of evaluation. And when I see, and I talk to other OBGYNs, and I hear histories like you mentioned in your case of being a cystic fibrosis carrier, and he was lucky because Scott's daughter was one of the 50% kids that they are only carriers in that scenario, but you may have a kid that has cystic fibrosis, the disease, and is something that potentially is lethal and is very serious. So if you're going to see a physician, even if you decided to do a home insemination, it's a good idea, because we can talk to you and we can do an evaluation to see if you are ready to get pregnant, okay? We take a history. We're going to find out first with a few questions, your age. With the age, I can know the chances of you getting pregnant. You're going to know the potential chances of having complications. I'm talking about the older that you may be, the increased chances of having genetic diseases related to the number of chromosomes. We're going to do some basic blood work that will tell me if you are anemic or not, if you need to take over-the-counter iron. Because imagine you get pregnant, and you see the baby as a nice baby growing inside your tummy. You can see that as a parasite that is sucking all your blood and your oxygen, okay? And if you're not ready to do that, okay, you may be serious complications, okay? So we are going to know if your kidneys or liver is working appropriately, okay? And we may run some specific tests to see if, for example, the tubes are open or not. The test that is called hysterosalpingogram or HSG, an X-ray, to see if the tubes are patent is very important to be done, even if you do not have any risk factors, pelvic surgeries, appendectomies, pelvic infections, STDs, that may potentially block the tubes. We run some blood tests to see the quality of the eggs. You may have heard about running on the 2nd, 3rd, or 4th day of your menses the FSH, a hormone that the brain releases, and according to the level of this hormone, we'll know the quality of your eggs. I mentioned the age, but this test can give you an idea within your age group how is the quality of your eggs. So we ran an evaluation that, talking about money, if you have insurance, regardless of your insurance covering or not infertility treatment, most of the times the insurance will do this type of evaluation. So most of the insurance will cover the X-rays, blood work, because you're not doing any type of treatment. Treatment that will be the inseminations is a different story, but the evaluation generally is covered. So doing all of this testing, including genetic testing, you are able to know if, for example, you are a carrier of a cystic fibrosis. There are like 100-something diseases that we can evaluate you, and you are going to potentially be a carrier of those diseases. So when you decide to do an insemination and we make you contact California Cryobank, some of those diseases are already being screened automatically by the bank, okay? Cystic fibrosis, SMA, or other ones. If there are another unusual diseases, they can also run the test, because in that way you can prevent having a child with some of those genetic diseases. So that's the initial evaluation that is done. And then you can potentially, if you decide to first do an evaluation in a physician's office, in an infertility specialist's office, I wouldn't advise you to do home inseminations, but you may decide and do it in the comfort of your home. When we do the treatments in the office, you can do what we call a natural cycle insemination, in which you will not be taking any medications. We'll monitor your cycle, potentially doing what we call the ovulation kits to measure the LH surge when the brain releases a hormone called LH, and in that way may identify if you are ready to ovulate, to do the appropriate timing of the insemination. Sometimes we give you medications by mouth to make you ovulate or to improve the number of the eggs that you are going to ovulate on a cycle, and with either some blood work, an ultrasound to see the follicles that they are ready to ovulate, and the add of the testing in urine to see if your hormone LH is ready to trigger the ovulation. We'll do the timing of that insemination very appropriate. Potentially, your OBGYN may help you in scenarios like this one, but the disadvantage of doing this with a general OBGYN is that generally they're not open on Saturdays and Sundays or weekends or holidays to do this type of treatment. So generally 99% of these inseminations are done within an infertility center, okay? So the insemination is basically a procedure in which the sperm that we receive, in case that is done through an anonymous donor through a bank, is processed in the lab, and through a small catheter, like a plastic tube, the sample is placed through the cervix inside the uterus. For the patients, will feel like a pap smear that takes longer. Mm-hmm. It could be 5 minutes, it could be 10 minutes. Most of the patients, they don't feel anything. Some of you may feel some cramps. In very, very rare cases, the inseminations may be very difficult and you may have more cramps and more discomfort, but it's not a painful procedure. You do not need anesthesia. You do not need any particular type of care after that. You stay for 10 minutes after the insemination and then you do your normal activity. Sometimes we do 2 inseminations depending on the findings on the ultrasound, and we tell you to come back the next day to do another insemination. And roughly 2 weeks after that day, we'll do a pregnancy test to hopefully see that you are pregnant. We may give you what we call a luteal support. It's basically progesterone, the hormone that helps support the pregnancy during the second phase of the cycle. Could be through vaginal suppositories or sometimes oral medication. That's the most simple type of treatments that we may offer you to achieve a pregnancy. If we're going to do that, generally we'll suggest you to do the X-ray to see if the tubes are open. But many times, I talk to the patient and I said, listen, if you don't have any risk factors, we may do inseminations without doing that type of evaluation. Because the worst that is going to happen is that you will not get pregnant because the tubes are blocked. So I explained to you, but if you don't want to go through the discomfort of the X-ray, you do not need to do it. But if you have a history of an appendectomy that was complicated by a pelvic infection, I will strongly recommend you to do it. Generally, when we use the medication, we'll suggest you that you can go through anywhere 2, 3, or 4 cycles of insemination. Cycle means a month of inseminations. You may do 1 or 2 inseminations per cycle per month. After 4 months, generally the success rate decreases significantly, and we are ready to move to another type of treatment. Each case will need to be analyzed individually, but sometimes you may suggest to do a laparoscopy, a surgery in which, under general anesthesia, we put the scope through your navel to see if you have endometriosis, a disease that is associated with infertility. If you have a history of tubal blockage or pelvic adhesions, we may offer you that at the beginning before you do any type of treatment. So those are some options that we may discuss. Then, after trying the inseminations with the medication by mouth, another option is trying inseminations, but now with injectable medications. They are hormones that are basically going to act directly, stimulating the growth of follicles, the structure that are on the ovaries, and they have the eggs inside. The eggs are very small. You get a millimeter divided 12 times, that's roughly the size of an egg. So when you do ultrasounds, you don't see the eggs, you see just the follicles, okay? So the other treatment will also be using the sperm, and you're doing an insemination, but what is different is how you stimulate the female to produce eggs, in this case with injectable medications. These hormones cannot be taken by mouth because will be destroying the stomach. The clomiphene is something that you take by mouth without any problems, and it's acting in a different way. Generally, we may do from 1 to 3 cycles of injectable medications plus inseminations. If at that point there is no success rate, there is not pregnancy, we suggest to move on and do another type of treatment that will be in vitro fertilization. We do not need to do it specifically in that order. Of course, if someone comes and will do the hysterosalpingogram, the HSG, the X-ray, and the tubes are blocked, we may tell you, you need to either have a surgery to correct the tubes, or we go through in vitro fertilization. If you are 40 and you want to have 3 kids, like you mentioned it before, Scott, then we'll probably tell you, you need to speed up, and if you want to do the most effective treatment, you need to do in vitro fertilization. Basically, in the in vitro fertilization, you give medications, always injectables, unfortunately, to stimulate the follicles, produce several eggs. We remove eggs from your ovaries. Because we do that, the procedure will be painful if we do it without anesthesia. So we have an anesthesiologist start an IV line and give you some IV sedation. It's an outpatient procedure. That means that you go home on the same day. You do not need to do it in the hospital with certain exceptions. We remove the eggs, and then when we have the eggs in the lab, we put them together with the sperm. Potentially, we may do what is called ICSI, that is injecting each one of the eggs with one sperm to try to increase the chances of fertilization. The next day, we'll see under the microscope how many eggs fertilize. You get a phone call from the embryologist telling you that, imagine 18 eggs and 16 fertilize. But you need to know that the process is relatively very inefficient. Even if you start with 18 eggs, you may end up with transferring 2 great quality embryos and having only 2 embryos frozen. I mentioned it that transferring 2 embryos 5 days after the aspiration, because that will be the ideal scenario. We reach what we call blastocyst, that is a different type of name to designate an embryo. Embryo is when the egg is already fertilized by the sperm. And we put generally 2 embryos because that will give you the highest chances of you getting pregnant. But we put 2 embryos, then you have roughly 35% chance of having twins. For many of you, maybe a great news, because you want to have this done maybe once and that's it, that's over. But the multiple pregnancy is a high-risk pregnancy. And don't imagine to having 2 healthy kids screaming at night and you don't sleep at all. Imagine that potentially you may have some kids that are screaming at night, but they are not healthy. Particularly if we are talking about triplets, that may be a reality. Don't think about the octomom, okay? Because that was an exception, okay? Probably everybody knows about her, but that was in vitro fertilization, and they transferred 6 embryos. What was really something exceedingly unusual, okay? So the concern is with twins and triplets. There is something that we offer to all the patients, is what we call SET, or elective single embryo transfer. That is a great possibility to significantly decrease the chances of multiple pregnancy. So if any of you, unfortunately, needs to reach the point of doing in vitro fertilization and you want to minimize the chances of multiples, we transfer only one embryo. The advantage of that is that the chances of twins decrease, but they don't disappear, because you have a 5% chance that that embryo split and you have identical twins. And the chances of getting pregnant decrease also, because you are putting only one embryo. You may add some type of different procedures to try to increase the chances of getting pregnant when you do a single embryo transfer. For example, doing what we call PGD or PGS, that is basically doing a biopsy on the embryo. We take 1 or 2 cells. A blastocyst has something around 100 cells. We take 2 cells, we do a biopsy on those cells, we run the biopsy, and we know the chromosomes. The chromosomes is basically the software of a cell where all the genetic information is located. And you may hear about that we have 46 chromosomes. Females, they have 46XX. Male, they have 46XY. So doing this type of testing, you may have the additional option not only of selecting a child that is not affected by either an extra or missing a chromosome, or you may potentially do sex selection if you want to have a girl or a boy or whatever you decide to do it, okay? So that's another topic. When you do in vitro fertilization, that technique allows you to do what is called the reciprocal in vitro fertilization. You have a lesbian couple and they want to have a baby and they want to try to share that experience in the biological way. So one of them can go through the process of stimulation to produce eggs. Those eggs may be removed from partner A, and they are fertilized with the sperm. But the embryo or embryos, instead of being transferred into her uterus, is transferred into the partner B. Okay, so that will be what is called reciprocal IVF. If that's the scenario that I have many times when couples, lesbian, are coming to see me, I will listen to them, and they generally come with a plan idea of who's going to be the donor and who's going to be the recipient. But generally in my mind, always I'm going to select the donor on the younger partner, okay? Because that will give the highest chances of achieving the pregnancy. Of course, each case will be particular, because you may have one of the partners that may be younger, but they have severe endometriosis, and endometriosis affected the quality of the eggs. And she may be younger, and she's 28, but the older member of the couple is 30, and that's not a significant difference. Okay? So that is what we call reciprocal IVF. Okay? So I think that I discussed most of the treatments, most of the options for you.